let's switch gears now to emerging threats. Emerging threats in opioids in particular. Around the turn of the century, the Bayer pharmaceutical company was on a roll. They had just found a way to efficiently produce acetyl salicylic acid, also known as aspirin. Success. Less side effects than salicylic acid. I got acetyl salicylic. It seems to work better. And I'm helping so many people right around the turn of the century, right? Why don't we put an acetyl group or two on morphine? Okay? So we synthesize diacetylmorphine, which is the chemical name for heroin. Acetyl groups make morphine more lipid soluble and pass the blood-brain barrier easier. So it is more or less reinforcing the morphine. Anyone? More reinforcing the morphine. So here we are. Taken from the poppy seed, more prominent since opioid prescriptions have decreased. Boy, we thought we solved the problem there. Let's cut down oxycodone and hydrocodone and we fix everything, didn't we? It's all Jaco's fault because pain is the fifth vital sign, right? We fixed it. No, we didn't. Addiction was still there. It's the disease we're treating, folks. It's the disease we're treating. The enemy is who? The disease. Education, identifying the illness as early as we can, and treating the illness. I always said, when we're treating patients, look, if the genetics is there and the disease is there, it doesn't matter. If you put me on an island and there's only coconuts there, I'll find a way to ferment the coconut to change how I feel. I will find something to change how I feel if I need to, and it's pertinent to my survival. Again, that's what this is about, right? It's low dopamine in the nucleus accumbens, which is the survival center. It's 5 days with no water. So it seems with our prescription restrictions and the mortality data that I'm going to show you, we haven't solved the addiction crisis, and now we have a more powerful vehicle that causes death more easily. I should mention, heroin's twice as potent as morphine. It acts faster for shorter duration than morphine, which means what? If you were at the last lecture, you know shorter half-life means more addicting. 3 major metabolites of diacetylmorphine or heroin are 6-MAM, 6-monoacetylmorphine, morphine, and morphine-3 glucuronide, and morphine-6 glucuronide. But the real one that the unique metabolite, if you find monoacetylmorphine, if you find 6-MAM in your urine, that is pathognomonic for heroin use. The way it breaks down metabolically, that indicates heroin use, not another opioid. So if your urine has 6-MAM in it, you know that the culprit was heroin. So this is another sobering statistic. The DEA public safety alert. Now, one pill can kill. The DEA has found that fentanyl-laced fake prescription pills analyzed in 2022, 6 out of 10 of them now contain lethal doses of fentanyl. And that's an increase from 40% from the year before. So now 60% have lethal doses of fentanyl. So this is the part that's especially scary, and probably, besides the disease of addiction is present, these are also the folks who may be experimenting. This is the one-off and I died. This is the one-off I didn't, I was at a party or I was just trying for the first time this pill that looked like candy in a bowl or whatever it is, pressed pill, and it had fentanyl and its analogs in it, and I don't wake up. That's not all the cases, but it certainly introduces more risk because it's so potent. 6 out of 10, 60% of those pills have potentially lethal. We're talking powerful stuff that's on the street. Kind of moving, from heroin to fentanyl now. So we talked about heroin a little bit, diacetylmorphine. Now we're talking about fentanyl, which is a synthetic opioid 50 to 100 times stronger than morphine. Certainly a major contributor of the fatal and non-fatal overdoses. 2 types of fentanyl, stuff we have in the OR and stuff illicitly manufactured. Both are considered synthetic opioids, but the pharmaceutical is often prescribed to treat severe pain or during surgery or advanced cancer. The most recent cases, though, of fentanyl-related overdose are linked to the illicitly manufactured fentanyl distributed through illegal drug markets for its heroin-like effect. It's often added to other drugs because of its potency, which makes drugs cheaper, more powerful, more reinforcing is kind of the key word there. A repeat customer if they live through it. But one of the things it used to be, this is just going back 5 years, the only people who came in with fentanyl addiction were anesthesiologists. Because there was no fentanyl really on the street at that time, or very minimal. Very minimal. So just a word about fentanyl or anesthesia. Amongst us, as colleagues in medicine, anesthesia has the highest rates of addiction in the medical field. Physicians have rates of addiction similar to general population at that 16.5%. It basically is throughout. It doesn't matter education. The same prevalence of addiction in general. However, when you look at us by field and you look at us in discipline, the discipline of anesthesia has the highest rates. So, Mark Gold and others did a study at the University of Florida years back looking at why is it. And one of the interesting things they found, it had always been hypothesized that it was just access. They had access to fentanyl, anesthesiologists or physicians. But it seems as though there was a priming of the pump with folks who had genetic vulnerability. So in other words, I'm behind the sheet, right? And I'm right over the face of the patient who's exhaling volatile gases and fentanyl that is given to them during the operating room. And I do cases back to back to back to back. And I'm stressed and I'm tired. And I have a family history of it, and I'm just susceptible to it. It may be a priming of the pump. So there's some interesting, work done there saying that it was actually more than just access that had to do with the high rate. I digress. Fentanyl and its illegally used fentanyl, most often associated with recent overdoses made in labs. The synthetic fentanyl is sold illegally as a powder. They can put it on paper, put it in eye droppers, nasal sprays, or made into pills that look like prescription opioids. I've seen some of those pressed pills that look like Basicolin Blues or 30 milligram oxycodone tablets, but they're not. They're filled with fentanyl and xylazine or just fentanyl. Fentanyl can be injected, snorted, sniffed, smoked, taken orally by tablet. Many illicit producers are mixing fentanyl with other drugs like xylazine, heroin, cocaine, methamphetamine, MDMA. As a result, overdose deaths have increased dramatically. Why is it that it's being mixed? If I increase the number of pathways, so the final common pathway is dopamine release in the nucleus accumbens, but what if I can get at it through 3 or 4 different ways? What if I can hit the GABA A receptor with something that looks like a benzo or a barbiturate or alcohol, and then I can hit the GABA interneuron with morphine, and then I can hit dopamine reuptake with a stimulant, something that looks like cocaine or methamphetamine. I have 3 mechanisms of action whose final common pathway is dopamine release in the nucleus accumbens. So the way my disease of addiction gets worse is I introduce different classes of substances in different routes of administration. Everybody always asks, am I going to make their addiction worse by giving them buprenorphine or Suboxone? Am I going to make their addiction worse by giving them methadone? They already have addiction. The only way to make addiction worse is how? They take a route of administration that's faster, like intranasal, intravenous, or smoking it, or you give them a new class of substances that their body has never seen before. So don't ever worry about making the disease of addiction worse by helping them with a prescription for buprenorphine if they've already seen opioids and snorted them and injected them in their arm. Okay, the only way I make the disease worse is to change the route of administration or I change the concoction of chemicals. And that's why the dealers and why people trying to feel better, see, one class by itself is not working anymore, right? Tolerance. I'm doing more and more for the desired effect, but at some point, it's not working. So I have to add something else to it. So that's why it's no accident. It's very, I'm seeking, and it's designed by people who are manufacturing this stuff. But here's the sad part, is I'm not paying attention to respiratory ceiling, respiratory depression. I'm not paying attention to an endpoint. I'm seeking a feeling. I'm seeking relief. So no matter what anybody says to me, I'm not looking at that consequence, that endpoint. And so when I combine things, I'm actually putting myself in more danger because why? Respiratory depression, the ceiling. I already had myself close to the ceiling with just opioids, and then you add sedative hypnotic quality, and now I'm over the line, and I stop breathing. So here's why we're here. This is why we are here. Mortality figures. Overdose deaths. Look, there's our graph where we stopped prescribing as much hydrocodone and oxycodone. And then it took off again. 106,000 people died of overdose in 2021. So why we're here is medication access. What medication? Well, at least buprenorphine. That can save lives. And training expansion. Training of what? Training to recognize this is a disease. Addiction is a disease, medical disease. And I need to identify it. And so training like this is supposed to give you enough armamentarium, enough insight to say, I see something. And I want to get that evaluated, whether I do it myself or I do it through somebody else. It's a medical illness that will shorten lifespan and will cause morbidity as well. So we're here because of this graph. This, I think, was the cherry on top in a negative way for the DEA to say enough death, enough pain. This medicine has enough data to say that it'll probably help rather than hurt. So we got to open it up because the graph has gone exponential. The graph has gone exponential. So we need to do something. We need to open the gates and stop restricting this medicine that we know helps. Again, I'm not saying it's the total answer, but it's part of the answer, I can tell you that. And we got to train people on how to evaluate this illness so they know when to refer people out, like it's above their head. Some of the stuff they just do themselves, whether it's in the hospital, in the clinic, or whatever. But I need to get the tools out there so they know when do I need to sit down with not only the patient, but the patient support system. That's the key here. And, how do you talk sense into somebody 5 days without water? You want to explain to them the molecular properties of the seawater? Dasani versus Zephyr Hills. You want to talk, it's a desperate situation, right? So you can't just sit with the patient who's not well in their mind and try to rationalize with them. They're beyond rationalization, but they are not beyond the good old amygdala, which is where the emotions are. They're not beyond the love of the people around them. Powder fentanyl looks just like many other drugs. It's commonly mixed with drugs like heroin, cocaine, methamphetamine, and pressed into pills that resemble other prescription opioids. And this is what we mentioned before. We're up to 6 out of 10 lethal. 150 people die every day from overdoses related to synthetic opioids like fentanyl. So I guess just breaking down a little bit further on the data. You wouldn't be able to see it, taste it, or smell it. And it's nearly impossible to tell if the drugs have been laced with fentanyl. Now, there are test strips for fentanyl, but they're not that reliable, to be honest. I wouldn't bet my life on it. You know, you can't. It's certainly one of many harm reduction methods where you say, look, you know, you should, you know, at least test it with a strip. And you won't pick up the analogs. You might not pick up carfentanil, and you might not pick up sufentanil. Carfentanil and sufentanil are stronger than fentanyl, and the fentanyl test strips won't get that. So it's, you know, part of we call, you know, there's a frame of thought which is like, you know, harm reduction, and it's shown to save and extensive life, and it's like, well, use test strips to make sure fentanyl's not in there. Well, we just heard from the DEA that 6 out of 10 pills have lethal fentanyl in there. So whether your strip says yes or no, I mean, you guys know the way numbers work and what you're testing for and what you're looking for. When the prevalence is high, it almost doesn't matter what the test shows, right? When you got the clinical symptom in front of you in the clinical picture, regardless of what the test, you know, it sounds like a horse, it's probably a horse. Okay, let's talk about the next emerging threat. We went through heroin, we went through fentanyl, and now we're at zalazine. Zalazine is an animal tranquilizer. On the street, they're calling it trank. And it's being found in a lot of the drug supply and linked to overdose death. The reason why is it's sedating, especially when you combine it with fentanyl. They're also combining it with cocaine, and it's cheap. You know, basically it's being used because it can cut the drug, but it can also potentiate the drug. You have the problem when you go to the emergency room because it doesn't reverse with naltrexone or naloxone. Zalazine is a non-opioid sedative, analgesic, and muscle relaxant, and it's only authorized for veterinary use in the U.S. It's not classified on the DEA schedules 1 through 5. People are typically using it by injection combined with fentanyl. They're usually not used as a lot of drugs because it's part of the pressed pills, illicit pills that are out there. Okay, and there's really, you know, no way to test for it. At least on the front end before somebody uses it. On the back end, we can see it and send out your analysis, the quantitative during drug screen. So people, you know, using zalazine, you can get dry mouth, drowsiness, hypertension, tachycardia. It's interesting. Then you go hypotension, bradycardia. What it is, and we'll be getting to this, is it's an alpha-2 agonist similar to clonidine. It's an alpha-2 agonist like clonidine, so you can picture, right? What happens when you do a lot of clonidine? People get hypotensive. People, you know, can get hypoperfusion of their brain. It can be sedating. Now, the other thing about it is it kind of resembles a phenothiazine, which is like a first-generation antipsychotic like Thorazine. And so we have also some anticholinergic properties. So it's this strange, you know, sedative muscle relaxant that also has anticholinergic and alpha-2 agonist that decreases norepinephrine. Soft tissue injuries are seen too. They have these necrotic skin lesions, you know, and they seem to not heal very well and form scar tissue that lasts and holds the deficits, you know, divots in the skin that stay. So certainly zalazine has increased the potential for fatal overdoses just because of the sedation, that respiratory ceiling I was talking about. When you find somebody's using and they're just right on the edge with their opioid tolerance and they don't realize it. They're right on the edge of respiratory depression and they have high levels of opioid tolerance, and then you go ahead and throw benzodiazepine or you throw zalazine in there. That's when the respiratory depression threshold is exceeded and they stop breathing. They might be more difficult to identify in clinical settings because they look like opioid overdoses and they're probably combined with them, but they really don't have an antidote, which is the problem. So they're going to need cardiovascular and respiratory intubation and support right away. So the half-life of that xylazine is 30 minutes. So you go very quickly, potentially from hypotension to hypertension, possibly. So back to it's veterinary medicine, sedative, analgesic, muscle relaxant, veterinary use only. Structure is similar, as I mentioned, to phenothiazines, which is that first generation typical antipsychotics like Orazine, and has some not only dopamine blocking but anticholinergic activities. Is an alpha, its classification primarily is an alpha-2 agonist. Onset within 10 to 15 minutes after it's administered in animals, and then maintained for an hour or two, and analgesia can last for 15, 30 minutes. And it's centrally acting muscle relaxant, can cause relaxation of skeletal muscles, and it complements the sedation and analgesia. Half-life in humans, as mentioned, somewhere between 20 and 50 minutes, and you can't, the detection window is short if you were to send it out. Being found in heroin, fentanyl, and cocaine. So in the typical distribution and sales for veterinary use, it's available in a liquid form and sold in vials, preloaded syringes for veterinarians. But they're prepared for the animal based on size and weight, and it's legitimately sold and distributed through pharmaceutical distributors. But that's not where the illicit xylazine is coming from. It's coming from the internet in liquid or powder form, often not associated with veterinary profession nor any requirements to prove legitimate need. A kilogram of xylazine powder can be purchased online for $6 to $20 per kilogram, and that would be considered a low price, as it's used as an adulterant that allows traffickers to adjust the amount of fentanyl or heroin used in the mixture. So that's being cut with it, and it's making management even more difficult in a lot of ways. So xylazine and fentanyl's everywhere, 48 out of 50 states. In 2022, 23% of fentanyl powder and 7% of pills had xylazine. So 1 out of 4 pills had the xylazine in it. And every region in the U.S., basically the prevalence is increasing, with the largest in the South. Xylazine was involved in 7% of overdoses in 2020. When they're looking at these syringe service programs, which is a harm reduction paradigm, looking to decrease the rates of infectious disease, in Maryland, they found that xylazine was in 80% of the drugs in that region. And then in Philadelphia, 31% of heroin had xylazine